Corneal collagen cross-linking, the evolution, is IC number 41, and Dr. Sujith Nayanar is the chief instructor.
A very good morning. I welcome you all to this IC instruction course number 41. The topic for this IC is corneal collagen cross-linking. Myself, Dr. Sujith Nayanar. I'll be the chairman for the session, and my co-chairman will be Dr. J.K. Reddy. So let's go on to the IC. The IC focuses on the various aspects of corneal collagen cross-linking. Let's begin with the evolution, how it came into existence. At the outset, let me thank the scientific committee KSOS for giving me this opportunity. I believe this is first time the corneal collagen cross-linking is being included in as an instruction course, and also this is a great opportunity to be part of this virtual Drishti 2020, which I am sure will be written in history in golden letters. So coming to the topic, this is the landmark paper that was published in 2003 after a series of publications on experimental works and animal studies on the effect of cross-linking on corneas. So in the last 17 years, this procedure evolved a lot from where it started in early 2000. And with a better understanding of the biological effects of the cross-linking, the indications are expanding and the contraindications are getting relaxed. So by this time, it has secured the title of gold standard procedure to stop progression in ectatic corneas. The global consensus on keratoconus and ectatic disorders in cornea, which was recently published, showed 83% of ophthalmic physicians are performing cross-linking, which shows that it is one of the most common corneal procedure that is performed today by the non-corneal ophthalmic physicians. So it's all the more important that we must learn it properly, we must practice it properly to avoid any complications related to the procedure. In this particular paper, these were the inclusion criteria for the procedure, which included the diagnosis of keratoconus confirmed on topography and slit lamp, documented progressive keratoconus, minimum pachymetry of 400 microns, that is after removing the epithelium. The age range of the patients was from 13 to 58 years. Average age was 31 years. The moderate to advanced keratoconus patients were selected, and the range of keratometric value was 48 to 72 diopters. The conventional protocol of procedure that was followed in this particular publication is known as the Dresden Protocol, which is still the standard protocol, which is introduced by Wolensek et al. As per this protocol, the epithelium is removed for 7 to 8 millimeters of diameter, and 0.1% riboflavin in 20% dextran is used for soaking the cornea for almost 30 minutes, followed by 30 minutes of UVA light application of wavelength 370 nanometers with an irradiance of 3 millivolts per centimeter square with an effective dose of 5.4 joules per centimeter square. So this is known to cause a complex photochemical process that consists of an aerobic phase, otherwise known as the type 2, and type 2 photochemical reaction, or an anaerobic phase, which is known as the type 1 photochemical reaction. The riboflavin, which we all know is a photosensitizer, is being used as a photosensitizer, but it has got two other roles as well. It acts as a protective agent for the lens and other deeper structures from the ultraviolet rays mediated damage, and also helps in cooling the corneal structures from the thermal effect of the ultraviolet rays. So as part of this type 1 and type 2 reactions, the riboflavin radicals and singlet oxygen active particles have been formed in the cornea stroma, and they help in formation of the covalent crosslinks between the fibrils of collagen and the proteoglycans. So as part of this cross-linking, it was clearly, the Wolensek demonstrated clearly the stiffening effect of the cornea in porcine as well as the human cornea. This picture is from that particular publication. He reported there is 329% increase in the biomechanical rigidity and a 4.5-fold increase in the Young's module after cross-linking. The Young's module, or otherwise known as the elastic modulus, is in the essence of the stiffness of the material. In other words, it is how easily that it is bended or stretched. To be more exact, the physics and numerical values are worked out like this. The Young's modulus is equal to the stress by strain. So an increase of Young's modulus by almost 42% in human cornea was also reported by the other authors. Other observed biological effects include the cross-linking. It is well known that the cross-linking effects are confined to the anterior 250 microns of cornea, with the next around 100 microns being the intermediate zone with a smaller degree of cross-linking. And the cross-linking also has demonstrated that after cross-linking, there is the increased diameter of the cross-link type 1 collagen, visible intrafibrillary crosslinks, whereas the interfibrillary crosslinks are still inconclusive. So the corneal responses and the effectiveness of the cross-linking treatment in halting the progression of the keratoconus has been investigated both in laboratory and clinical settings and as well documented. What are the clinical effects what we see? Clinically, it has been proven to stop the progression in around 93% of cases, and very significantly, you can see that the demarcation line, what you see here in the picture is the demarcation line being shown by an OCT, anterior segment OCT, but in the slit lamp examination also, you can see in at the 50% or at 60%, two-thirds of the cornea, you can see a demarcation line, which demarcates the cross-linked cornea from the posterior non-cross-linked cornea. An improved uncorrected and best corrected visual acuity, which is proportional to the topographic changes, have been reported. Almost 2 diopters of change in the K max has been reported. The thinning of cornea is very classical, which starts at the commencement of the procedure, and maybe it is demonstrated up to 1 to 3 months following the treatment. The recovery starts after 3 months and reaches the baseline thickness by around 1 year. But contrary to the various reports, there has been no effect on the limbal stem cells or on the tear film. This has not been documented in studies. And the corneal sensitivity has been fully restored within 6 months of the procedure. So it's not without any complications. So complications has been defined as losing 2 or more Snellen lines, and the rate of complication is around 2.9 to 3%, which includes sterile infiltrates, persistent corneal edema, endothelial burns, corneal stromal haze, infectious keratitis, and the failure of the procedure. So when we say about the failure of the procedure, as per this paper from Theosila, which was published in 2009, the failure rate of cross-linking, which includes the percentage of eyes with continued progression, was around 7.6%. And it was noted that a preoperative vision better than 20/25 was identified as a significant risk factor for complications, and also a higher keratometry value more than 58 diopters was a significant risk factor for failure, and also again the age of more than 35 years. So after so many years, the indications for the procedure is extended to other ectatic corneal conditions also other than the keratoconus, which includes the pellucid marginal degeneration, the post-laser refractive surgery ectasias, corneal infections in combined treatment protocols with the laser refractive surgery, and also for symptomatic relief in painful bullous keratopathy. So as the indications are expanding, the challenging situations we are facing are also increasing, which includes thinner corneas and resulting fear of endothelial burns in such conditions. The lower age limitations, when early can we do cross-linking, there is still no consensus on it. Other practical difficulties in pediatric population, like whether we need an anesthesia for a longer procedure, for difficult assessment post cross-linking regarding the progression. And also the collagen turnover rate and the need for repeat procedure, etc. In suspected early cases in potential refractive surgery patients, also this cross-linking is being utilized nowadays. So considering these challenges, that's why actually newer techniques and newer protocols are being introduced. Like the introduction of the epithelial on or the transepithelial cross-linking for thinner corneas and to avoid pain during the recovery stage, the accelerated cross-linking with a higher irradiation and shorter duration, the pulse cross-linking for intermittent cooling of the corneal tissue, for the chemical enhancers have been used to increase the riboflavin penetration and especially in epithelial on type of procedures, the iontophoresis cross-linking for better riboflavin delivery, photoactivated chromophore for keratitis, corneal cross-linking Pac Cxl, CXL with PRK, the Athens protocol, the customized or topo-guided cross-linking, epithelium on photorefractive intrastromal cross-linking PIXL for reduction of smaller amounts of myopia, and the latest one being the slit lamp based cross-linking. But the validation of the protocols are questionable and in many circumstances, and we may have to wait for longer follow-ups actually. We have to wait for longer follow-ups to see the to either to accept it or deny it. So sorry about it. So in this instruction course, we will be running through the various topics from what I have already mentioned. We'll start with the keynote address on the biological response and impact of cross-linking by Professor Dr. Rohit Shetty from Narayana Nethralaya, Bangalore, followed by the cross-linking in special situations like thin corneas by Dr. J.K. Reddy from Shankara Eye Hospital, Coimbatore. Professor Vishal Janji will be talking on the nuances on pediatric cross-linking, followed by the customized cross-linking will be introduced by Dr. Shreyas Ramamurthy, and finally we'll have the cross-linking in infectious keratitis Pac Cxl by Dr. Sharon D'Souza. So now let's move on to the program. I will begin with the keynote address. I invite Professor Dr. Rohit Shetty to deliver his keynote address on the topic, the biological response and impact of corneal collagen cross-linking. He's the vice chairman, clinician, and translational scientist, the GROW Lab, IBM's lab, Narayana Nethralaya, Bangalore. He's also an additional professor at Maastricht University in Netherlands. He's doing a lot of primary research in this field of corneal collagen cross-linking, and he'll be talking on the biological response of cornea following cross-linking procedure. I welcome Professor Dr. Rohit Shetty to deliver his talk.
Hello, friends, and thank you, Dr. Nair, for giving me this opportunity to share my presentation in your IC. My talk is today about biological responses in cross-linking and its impact on cross-linking outcomes. These are my financial interests. This is something which we keep seeing in our practice. We have patients with good flattening, suboptimal flattening, and excessive. This is which induces the unwanted haze, what you're seeing here. So all this creates a lot of confusion about what makes this to do well and what makes this not to do well. And this is something which has always been a big enigma. When we look at any disease today in medicine, including the coronavirus, it's all about everybody trying to find one aspect of it and making a whole story. It's like that old story we all remember of a six blind man and an elephant, and everybody picks up one part of the thing and makes his own story. So this is exactly what's happening to keratoconus also. So we thought, why not dissociate everything and try to make the story as a complete one through trying to understand from all aspects how a disease should be addressed. So we started looking at keratoconus from clinical outcome, molecular biomarkers, and imaging perspective. Now, what are biomarkers? The biomarkers are the ones which predict or tells you what is really happening in a body. probably one of the most common biomarker is your blood sugars or your hemoglobins. And now we have more advanced biomarkers. And biomarkers have shown a tremendous impact, especially during the COVID time, and we know how it works. The first thing when we start looking at the biomarkers is never to discard anything, including your Schirmer strip. And this is what happens in our daily OPD. After giving the consent of a patient signs here, and different things are collected. You can see the Schirmer strip here. It can sometimes for different procedures you need to look at on an MK medium, and here your tears. Everything has been collected and used, and we virtually use for biomarker work everything what we normally discard, and all after patient consent is taken. And it's kept at minus 80 degrees. It's like your bank where your name labeled and kept it. And we are proud to have one of the largest human biorepository in the world today. And whenever you want to study, you just go back, pick up this and exhume it, and it becomes like how you exhume a mummy, and you can take it forward. And if somebody is interested, they can visit our labs, and virtually from a tear film epithelium stromal cells, they can virtually do a lot. You can study the proteins, DNAs, cells, virtually anything, everything can be studied. What and how does it really impact in keratoconus? We have described that. This is part of my PhD work. We described that eye rubbing is just one of the events which occurs in the process. Then you have changes in your nerves, your inflammation increases, how your collagen degrades. Everything keeps changing in this process. And we published in this paper that MMP9 was one of the earlier biomarkers, and this we can actually treat or bring it down with cyclosporin at that point of time with no financial interest restasis. The second component is your collagen, how your collagen is tightly wound. Each of these fibrils are tightly wound, and each of these fibrils has how each of them is held tightly. And that's something as a very important enzyme called as a lysyl oxidase, which holds all of them extremely tight, and it keeps them tightly wound. And these lysyl oxidase are necessary to have the strength of your cornea. See, now this is how they are tightly wound, and when you use inhibitor, that means you dissolve it, you can see that the entire thing has become completely disturbed. And we also described that lysyl oxidase is very useful in outcome of cross-linking. That means if the eye has more lysyl oxidase, that means your cross-linking outcome is good. So that's a very important point which we need to remember or keep in mind. So when you try to bring it into schematic way, keratoconus eye, which has collagen and lysyl oxidase, this is lysyl oxidase, these are lysyl oxidase, it holds the collagen. When they're good, your outcome is good. When they're suboptimal, your outcome is big. And when they're very less, when the collagen and lysyl, so cross-linking is not as good as it used to be. So what is important is your outcome is not just based on your machines or your kind of technology use, it's also based on the molecular factors. And we also published about genetically altered lysyl oxidase causing ectasia. Now, how do you control this lysyl oxidase? And we did this experiment where these are the collagen. This is not on a human eye. This is done on, you can see here, done in the lab. And what we did was, when we did the experiment, we found that when you actually create inflammation, the lysyl oxidase actually get disturbed. And this is very important. For example, when there's high level of inflammation is in the MMP9, you can see that the lysyl oxidase actually reduces. So what it means that eye rubbing induces inflammation or dryness, and that induces the change in your lysyl oxidase. This is one of the reasons in that paper which I showed, we showed that the MMP9 can be brought down by cyclosporin, which today you can use the NANC-PF or restasis, a lot of other immune drops, all this stuff, all of them can block it. By reducing it, you actually reduce the inflammation. That is one of the reasons why the biomarkers is useful. And that's one of the reasons I always keep saying that you reduce the inflammation, your outcome of cross-linking, outcome of any procedure improves dramatically. And this is the paper which I just showed. You can see the change. And so even in my practice, I use a lot of cyclosporin-based products in keratoconus before and after cross-linking to stabilize them. So these inflammation, always a big question mark is this just where does this inflammation come from? And we just started looking at a completely new untouched territory of studying the microbiome, ocular microbiome. See, microbiomes we all know, but what is important is there are 30 to 40% of the microbiome, it cannot be cultured. That means you can't grow them anywhere. They are all commensals, they're not abnormal. So what we did was we started taking every bug and we started doing that DNA test. And from that DNA, we started identifying what they are. And we found something very unique bacteria for keratoconus, which is very important because these bacteria can actually bring in changes. So we also started looking at different pathways on the epithelium itself, because I said that there's a dryness, and autophagy was something which is very important. Autophagy is nothing but your housekeeper of your cells. It just cleans up all the dead cells. And this is a beautiful image from our own lab. And these are epithelial cells. These are your Golgi bodies, mitochondria, everything out there. And when there is inflammation, you can see that the cells are dying, and you can see that there is tremendous amount of stretch out there. And these things, we said that this can be reduced, or we can control them by using trehalose-based components. Trehalose actually induces better housekeeping mechanism. You can see that the change here. You can see that the cells are becoming better, and these things are very important in bringing out a change. So what is important is when you have a lysyl oxidase or inflammation or epithelium or autophagy induced, you need to control it. And when you control it, it brings in change. And this is a classic example of trehalose. You can see that how it is stabilizing, and you can see that there is also some amount of flattening, which means that you control the inflammation. Go back to my previous slide. Once you control the inflammation, it brings in more tight adherence of the collagen and lysyl oxidase. There's a very important role of vitamin D. We published this paper about how vitamin D brings in a lot of changes in your cytokine on your ocular surface, and this all changes the corneal nerves and dendritic cells, which are necessary for creating unpleasant sensation. We also found that in keratoconus, the vitamin D receptors were very low. Vitamin D receptors are from the epithelium. VDR means vitamin D receptor, and they are from the epithelium. And these epithelial are very much necessary to bring in hemostasis of reducing inflammation. So vitamin D is a very important factor in keratoconus because it brings in regulation of your inflammation, or it brings in stability of inflammatory molecules. And so what is important here is that if you are able to treat your vitamin D, then it brings in reduction in your inflammation in your ocular surface. Once you reduce ocular surface, remember all these things I said, the LOX will improve, collagen will improve, MMP will reduce. And this is what you require. And this will bring in a better outcome of cross-linking. Also, it will bring in a stability after you do the procedures. So how do I apply all this? IgE, like I said, helps in eye rubbing. And when your IgE is less than 300, I do all IgE tests for a lot of my patients who complain of eye rubbing. You treat with inflammation, anti-inflammatory, wait for stability. If the IgE is more, I usually refer to an immunologist, look for what allergens they are sensitive to. Desensitization is very important. Always maintain a vitamin D, and always I prefer an IM dose when it's less than 10, and I use a oral dose when it's more than 10. I use the WHO guidelines. reduce the signs of inflammation, use doxycycline when the lid signs, when the lids are inflamed, when there are MGD, topical steroids, when again MGD and other changes. Trehalose containing lubricant is my favorite choice because that induces autophagy. And cyclosporin has a huge role in stabilizing the ocular surface to regularize the epithelium, the corneal nerves, everything out there, which helps to regularize this. How do I know what I'm seeing from a molecular perspective actually happens? The best way to combine the science of molecules with imaging, and that's what we did. And the best way to do is we found that we can use we build this own prototype machine, polarization sensitive OCT, to understand the collagen. You can see that the collagen always is wound like this in the center, and in the periphery it is more tightly wound. And exactly what happens, you can see that it's like this, and in the periphery it is different colors, which means this is exactly what we are trying to see in our patients, and this is exactly what it is. And when we look at these patients again, I showed you these images. When we image this patient, this is a collagen image. You can see that the collagen is good here, but it's kind of wobbly, and which explains what we saw from the molecular pattern. And you can see that the collagen is poor, and in this patient, the collagen is terribly bad. Now, if you do cross-linking on that, this is exactly what I'm trying to say. We need good amount of logs, good amount of collagen to have a good outcome. And if you do the cross-linking, you see that it is good. And you can see that the cross-linking outcome is still okay. It's not as good as it should be. And compare it to this and compare with this outcome is good. So what happens is when you have this kind of a pattern, you can actually now assume that your outcome is heavily driven by factors of the collagen and the lysyl oxidase. So what are the futures we have? All this happens good in the lab, but what do you do? We need to bring it to the point of care, and this is what we're working. This machine is at present in our clinics. We would probably commercialize it in the next 2 or 3 years, and everybody could have a biomarker of the choice. Once you have a biomarker, then you can actually start linking which drug, liftigrast, is coming, a different lubricant, trehalose-based ones, or the cyclosporin ones. A lot of work is happening on the gene therapy from various diseases. This is our own lab where we are looking at the gene therapy as one of our areas of interest. We've been experimenting different gene therapies on the corneal surface by putting drops or injecting on the cornea. We used just a gel contraction method. This is not the cornea. Here we started using with the mouse model, and this is the mouse you can see here, and this is the OCT, and one of the early gene therapy for the cornea was attempted on this. At least we need to wait for another 6 to 8 months, sacrifice the mouse, take the corneas, and then see what is really happening. And finally, what I would say that it's a mix of molecules and imaging. And like I said, it's an imaging, the proper demographics, molecular factors, and predictive modeling will all form a mainstay in identifying which patient would do better or what would really change and what would happen. In this direction, we have our own very exciting to show our own software called AcuSim. It is probably going to be integrated into many diagnostic machine, because you can probably, now it's only on refractive surgery. In future, we'll have on keratoconus also, and then you can probably add whatever you know, and the machine would predict and tell you what is really happening. So finally, what I'm trying to say is the outcome of cross-linking or in keratoconus, there are tremendous amount of things which go on. Your inflammatory molecules, your hormones, you can see there's a tremendous amount of hormones, your cell hemostatic factors like galactin, lactoferrin, autophagy, chemical components is very important. When you write prescription, it contains zinc, copper is very important. Metabolic factors are very important. All this have a role in collagens, proteoglycans, reducing crossing like the LOX, and proteolysis. That means it increases MMP9, and all that makes your patient go into a KC. And all these factors has to be treated. Everything has to be treated before you do cross-linking, because if you don't treat them, then eventually end up in a poor outcome or a more haze. I thank my entire team of scientists at the Grow Lab, and my colleagues and all my fellows who Dr. Sharon, who's a consultant, Dr. Pooja, Dr. Gairik, and all of them who really helped me to make this presentation possible. Thank you.
Thank you, sir. That was a wonderful talk on the biological aspects. We will come on to the discussion at the end of the meeting. Now let us move on to the next speaker, my co-instructor, Dr. J.K. Reddy. Dr. J.K. Reddy will be speaking on the cross-linking, corneal collagen cross-linking in special situations like thinner corneas, post-LASIK ectasias, and pellucid marginal degeneration. Dr. J.K. Reddy is from Shankara Eye Hospital, Coimbatore. He needs no introduction. He's Director Technical at this Shankara Eye Hospital, Coimbatore. He's also well known for his innovations like InFocus IOL, the RIL phakic lenses, per-operative keratoscope, the titanium K-Pro, regarding keratoconus, the PTK on cone in keratoconus, and the intrastromal B2 injection for the C3. I invite Dr. J.K. Reddy for his talk.
Very good morning, and I thank Dr. Sujith Nayanar for giving me this opportunity, and KSY Scientific Committee. And coming to my talk on collagen cross-linking in special situation, talking after Professor Dr. Sujith, a PhD scholar, is difficult, but that too without knowing what he spoke about before me. So let me see what I can do in this short presentation. So collagen cross-linking in special situation is my today talk. And when it comes in Tamil Nadu, the only special thing is masala dosa always. And here the cross-links happens because of the heat, and it becomes a crisp and tasty one. In cornea also same, the physical bonds are the cross-links. Here is no chemical is permanently used for cross-linking, unless the leather industry or somewhere you use glutaraldehyde. Here the covalent bonds are formed physically with the riboflavin. It will be washed off over a period of time. So the Dresden Protocol is like a all or none, where it's like a basic foundation on which the cross-linking has developed. It's like a +21 diopters lens for every case of cataract. You don't use it, you don't titrate it to individual patients. So coming to the thin cornea, less than 400 microns is given as a guideline. This is with the epithelium off, so 450 microns with epithelium is the less than this, all are considered as thin cornea. So why the rule 400? The rule 400 is because of the safety to the corneal endothelium. The 3 milliwatt energy is what they found Dr. Walensek in his studies, that beyond that energy, if you use without riboflavin, this you have to remember, without riboflavin, this is toxic to the endothelium. But if you use adequate riboflavin, and most of the UV is absorbed in 300 and 400 microns, and very little, less than 20%, maybe 10 to 15% will reach the endothelium. So you can use 10 times more energy than which is safe without riboflavin, with riboflavin. So this coming to the amount of energy that is given in Dresden Protocol, 5.4 joules with a centimeter square, and diameter 8 millimeters. So here you need to remember this is calculated for volume of the cornea, not for the surface area. So Dr. Sporel has given a nice energy distribution, how much energy you need to use for each thickness in his theoretical calculation. This we can take as a starting point for thin corneas, and we can reduce the energy, total energy delivered, the fluence delivered for thin corneas. The change in the total fluence of energy, how you change the power into time is the energy. Either you can reduce power, or you can reduce the time, or you can reduce both of them, and you can change and you can reduce the energy appropriately for a thin cornea. The other method followed is in this thin corneas is swelling of the cornea. That's what routinely done with hyperosmolar riboflavin. You use it so the cornea becomes thicker and you reach the safe limits like that. Then the addition technology, where you put a contact lens, you achieve the same purpose, but contact lens should be UV, non-UV absorbable contact lens, or you can use any corneal tissue. Either you can use overlay and discard it off, or you can use inlay and it will strengthen the tissue. There is always two sides for a coin, and both are correct, both are true. So we can take what you follow. It all depends upon clinical interpretations and observations and hypotheses and assumptions, and most important is your what you believe, and what you believe is more appropriate for that particular patient. I go mostly by this sporal energy distribution, the curve which he has given. So I reduce my total energy for thin corneas. Then what is the endpoint? Endpoint is this haze, what we see in the first drawing in the first postoperative. Nowadays, we don't want to see any haze, just visible haze. This is too harsh, we believe. This is due to the effects of the UV radiation on the corneal stroma, which results in a little denser scar. So we don't want to see this one. We like to see a more clear corneas on the first day than this one. That is the endpoint. So that results in a very uniform, deep, nice cross-linking. The central one shows more harsh effect, and on both sides, which you are seeing, gives nice effect. So the another method we use is the intrastromal corneal lenticule. So a lenticule is cut in eye bank eye with a microkeratome, and nowadays these COVID, this eye bank has also become very precious, and we make a pocket with femto laser at a 150 to 200 microns depth. We make a pocket in a recipient eye, the patient, and into the pocket we insert the lenticule. And this is surgically done. We can do safely under topical anesthesia. You make a open the pocket, and they separate the tissues with a blunt spatula. Any spatula, you can use iris depositor or any spatula, so that it's already cut, so it's easy to separate. And into that you insert the lenticule. So the total thickness of the cornea will be increased here. So this method we follow where there is no corneal scarring or any other problems which will compromise the results in case of with a femto. So for femto, you need a very clear cornea to cut, and we insert the lenticule and we stretch it out, and then you can do a cross-linking over the surface. This is the post-operative appearance of the patient, and this is how the cornea looks in slit lamp, and this is the OCT picture showing increased thickness and stiffening. Then we can modify a little bit depending upon the size, shape, and location of the cone. And second special situation is the PMD. We have two here. One is a pure PMD where the central cornea is quite good, and the second one is the PMD with keratoconus where there is a thinness of the cornea and thinness. So for example, this is a case where you see a very thin cornea in the lower portion, and here also another example, and here is one more example of PMD, and here is example of both keratoconus and PMD in the same patients. So pentacam pictures does help us in, but the machine cannot show the thickness of the cornea in the periphery. We fail to see many times. But here, if you take this case, this is both a PMD and keratoconus where there is a thin cornea and a typical appearance of PMD. And this is a patient, for example, say central cornea is quite good, and you see a keratoconus picture, and there pure case of PMD, where is another example where is a pure PMD where central cornea is quite good. What I do is I do cover the half of the cornea, superior half, and do in the lower half only cross-linking, but I involve in PMD cases till the limbus. Instead of central 8 mm till the limbus, I do cross-linking. I found it works well. And some cases, I do inject intrastromal riboflavin. This is a special one, not a routinely available in the market. You have to get a special one and inject, and you can do. So immediately after injection, the thickness increases, so it's much safer. And there are a few cases of PMD where the cornea will be very thin in the periphery. Like in this case, it's you can see here it's less than 226 microns, and it's a stroma. There is hypertrophy of epithelium, so the stroma is really thin. So these cases, what we are doing right now is we are making a stromal pocket. This we have to do manually. You cannot use femto because femto is very difficult to do in the periphery, the pockets, and this is a bit risky. Sometimes we do by I had few perforations posteriorly, but they are manageable. And somehow it separates very nicely the tissue here. We have to be a little gentle. And after making a suitable pocket in the inferior half, you can insert, will insert a freehand shape, corneal lamellar. This is not full thickness. This is a lamellar corneal graft, which is around 300 to 400 micron, 300, maybe 250 to 300 microns is good enough. So we insert that into the pocket and we suture it. And we do cross-link these cases because some of them have associated keratoconus. So this is how it looks post-operative in the lower portion in the OCT pictures. So early treatment comes to post-LASIK ectasia. This is my third third special condition, where what we found is the early treatment is better the prognosis. Small refractive correction can be done on the flap. So either with a TopoLink or with a wavefront link. Most of the time I prefer a wavefront link. Under correction is the rule. And I use a small optical. I don't use a 6 millimeters optical zone. I use either 4 to 5 millimeters optical zone in the central area. And another method I do in these cases is cone-centered Pdk. So this is the case of early keratoconus optical LASIK. So we did a wavefront ablation and we got a nice central zone, and this is a differential map showing the difference between the two. So coming to the PTK, the cone-centered PTK, here we decenter the PTK onto the cone center. I do around 55 to 75 microns depth and 5 to 6.5 millimeter zone. So the advantage here is, the concept is the epithelium is thinnest over the steepest apex of the cornea. The thinnest cornea is not the steepest cornea most of the times, and the PTK removes more tissue in the center. So you limit the cross-linking only to the conic area, and once the Bowman's layer is removed, we found that riboflavin penetrates much faster and much deeper. So this is the one example I will show you how we plan. So for example, in this case, with this, the apex of the cornea is 2 millimeters from the center. And so these are the values we get it. X is 0 and Y is -2. This is what we enter into the machine, into the excimer laser when you are doing PTK. And this is not the same patient, this is different, but I will show you how the PTK zone is decentered onto the cone when we are applying the laser. You can see this is not in the pupil center, it is decentered inferiorly and slightly temporally depending upon the XY axis we enter. These are the few examples. This is the case with the keratoconus, early keratoconus. This is the post PTK with C3R. This is another example where you can see in the right side, there is a asymmetric bow tie, which becomes more symmetrical and vision improves dramatically in these cases. The key points we need to I want to tell you is the same energy, more the duration, more the effect. For example, you are using 5.4 joules of energy, and if you use for more time the same energy, you get a more effect. For example, using for 20 minutes, it gets more effect than if you use the same energy in 3 or 4 minutes. So it doesn't obey the Bunsen-Roscoe law. Then the best corrected visual acuity is the most important parameter which decides the treatment plan. And the corneal topography, location and size of the cone, we have to consider when you plan for the treatment, and the amount of and it's better to do less than more. That's what I learned in these 15 years of collagen cross-linking. And another important point is visual acuity is paramount importance. So what is a preoperative best corrected, uncorrected visual acuity? It is not the shape alone that is important when you are deciding and planning for collagen cross-linking. We need to preserve the vision or improve the vision post-operatively. Bringing a good shape doesn't matter for patient. Thank you very much. And I again thank Dr. Sujith for giving me this opportunity.
Thank you, sir. That was a fantastic talk enlightening us with the various newer methods and protocols used in special conditions like thinner corneas. We will discuss about a few points mentioned here at the end of the meeting during the discussion time. Now let's move on to the next topic, that is by
Professor Dr. Vishal Janji. He will be speaking on the nuances of cross-linking in the pediatric population. Professor Vishal Janji is the Professor of Ophthalmology, Cornea, Cataract and External Disease Services, Refractive Surgery Services at University of Pittsburgh School of Medicine, US. He is currently the Vice Chair for Clinical Operations and Director for Clinical Trials in this department. His area of research interest include pathogenesis, etiology, and treatment of dry eyes, keratoconus, genetics management and its outcome, corneal transplantation, imaging, and corneal infection. I invite Professor Vishal Janji to deliver his talk on pediatric cross-linking.
I do not have any relevant financial disclosures. As we already know that keratoconus is characterized by axial, central or paracentral stromal corneal thinning. Visual acuity is lost mainly due to progressive irregular astigmatism. Various factors have been associated with the occurrence of keratoconus, including genetic factors, biochemical factors, environmental factors, and biomechanical factors. Clinical presentation is usually early in life with progressive impairment of vision, irregular myopic astigmatism, epithelial iron deposits, corneal scarring in late stages, and rarely patients will present directly with acute corneal eye drops. Now, treatment modalities include glasses and contact lenses or intrastromal rings and corneal transplantations. All these modalities, they improve vision but do not alter the course of the actual disease. The new goals for management of keratoconus include halting the disease progression and then visually rehabilitating the patient. As far as reducing the progress of the disease is concerned, collagen cross-linking has been established as a suitable technique for this purpose. The riboflavin-mediated procedure frame shifts a weaker cornea to a stronger cornea into a safer new biomechanical level. Randomized controlled trial, specifically from Australia, Melbourne, Australia, has shown that the outcomes at 3 years, 5 years, and even 6 years, they are very good after collagen cross-linking. It causes significant decrease in Kmax value and significant improvement in uncorrected visual acuity after cross-linking as compared to controls. Different protocols for collagen cross-linking have been described. Conventional cross-linking involves 30 minutes of riboflavin eye drops followed by 30 minutes of UVA irradiation. In transepithelial cross-linking, we do not remove the epithelium, so consequently this technique has become more popular in children. For cross-linking in thin corneas, we can use hypoosmolar riboflavin and we can continue to use intrapachymetry to make sure the cornea is not thinning out. In high fluence or accelerated cross-linking, we only soak the cornea for 5 to 10 minutes followed by 20 to 30 minutes of UVA irradiation, thereby reducing the overall surgical time. Sometimes we combine cross-linking with refractive procedures, especially surface ablation such as PRK. Now, in terms of pediatric cornea, we know that the mean keratometry declines from birth to about 54 months of age. We also know that the mean keratometry in the between the birth and 6 months of age is about 47.5 diopters. The cornea stabilizes at approximately 4.5 years of age with an average K readings of 42.69 diopters. There is an inverse relationship between age and severity of keratoconus. Keratoconus in children is significantly more severe at the time of diagnosis, and also pediatric keratoconus has greater risk of requiring a corneal transplant. It has been shown that the progression is fast as compared to adults in children in at least one study from 2008. Thinner the corneal thickness or steeper the keratometry representation, greater the risk of progressive corneal thinning. This study was published in JAPOS in 2016. The diagnosis of pediatric keratoconus is slightly different from adults. Ophthalmoscopic signs are more frequent in children. Asymmetry of keratoconus is also significantly more in children. That means one eye might be more involved as compared to the other eye. And the cones are more likely to be centrally located in children, which tells us the cross-linking might be more beneficial since the cones are central. We do face diagnostic challenges in pediatric keratoconus, mostly due to the scarcity of functional complaints in children, especially before the age of 7 to 8 years. Visual loss is more often unilateral, and that is why it might be missed because the child might be using the other eye. High accommodative power in children may also compensate for distortions induced and delay the onset of functional complaints, which are commonly seen in keratoconus in adults. We also know the keratoconus may occur in isolation or be associated with syndromic problems such as Down syndrome. It is also commonly associated with allergic eye disease such as ocular atopy and vernal keratoconjunctivitis. There is significant evidence that eye rubbing advances the progression of keratoconus and may compromise the outcomes of cross-linking. 80% of children in one study were shown to be eye rubbers. Intraoperative challenges in pediatric cross-linking, they include use of general anesthesia, especially when the children are 12 years or younger. I'm sure there are many people in the audience who would say that they have operated on children less than 12 years of age, but we all know that it is not a simple thing. Accelerated cross-linking can reduce the GA time and risk because the soak time is reduced to less than 10 minutes. So average time for standard cross-linking is 1 hour. For high fluence cross-linking, it can be anywhere between 25 to 30 minutes. Topical anesthesia, as I said, might be used if the child is cooperative enough, especially if they're between 12 to 18 years of age. So this is again showing you decrease the time by using accelerated epi of cross-linking, or make it less invasive by using epi on cross-linking where you do not remove the corneal epithelium. Accelerated cross-linking approach has been shown to be equally effective as compared to conventional cross-linking in pediatric keratoconus. The study showed the uncorrected distance visual acuity, the corrected distance visual acuity, flat and steep keratometry after accelerated cross-linking was pretty good in pediatric keratoconus. The progression was halted, and the visual acuity, keratometry, corneal aberrations were notably improved. Of course, it saves time, as I have mentioned just now. It increases the compliance, and it might obviate the need of general anesthesia in slightly older children. We still don't know which technique is the most effective. We know conventional cross-linking definitely causes more flattening as compared to other techniques. So there is an argument for using conventional cross-linking in children because you want maximum flattening. More data coming from European countries has shown that repeat cross-linking might be needed 7 to 8 years after initial cross-linking. So if you are doing aiming for maximum flattening in cross-linking, you might as well go for conventional cross-linking in children. Accelerated cross-linking, definitely you end up spending less surgical time. Compliance is better, especially in children. In transepical cross-linking, efficacy might not be as good as conventional cross-linking. So as I just mentioned, the disadvantages of epi on cross-linking in pediatric keratoconus, they include reduced efficacy. In some studies, after 12 months of stability, the simulated maximum K value actually worsened at the end of 24 months. And 50% of patients treated with transepithelial cross-linking required treatment with epi off cross-linking when we had to repeat the cross-linking. In terms of outcomes of cross-linking in children, one study showed that 95 out of 119 eyes diagnosed as having progressive keratoconus, when they underwent epi off cross-linking, they were followed for 1 year. There were 3 age groups: pediatric patients less than 18 years, adolescent 18 to 26 years, and adults more than 26 years. Topographic cones were more central in pediatric corneas. Pediatric corneas flattened 1 year after cross-linking by a mean of 1.8 diopters compared to 1.1 in other age groups. 1 year after cross-linking, the corrected distance visual acuity improved in all age groups, with highest improvement in children. After cross-linking corneas in children, they showed more corneal flattening and better corrected distance visual acuity. It was therefore concluded that pediatric cross-linking is equally safe as compared to adolescent and adult cross-linking. One of the good studies which was published about 10 years ago is the Sienna cross-linking pediatrics trial, which had 152 eyes of 77 patients aged 10 to 18 years. It's one of the largest studies with longest follow-up of up to 3 years. Topographic and functional improvement was observed in 80% of the cases. Keratoconus was stabilized, and all patients demonstrated significant visual function improvement. It was noted that the visual recovery was better and faster in eyes with less than 450 microns corneal thickness compared to patients with thicker cornea, and there were no adverse events. Treatment failure is defined as increase in Kmax value of more than 1 diopter 12 months after the cross-linking. Compared to failure rates of 0 to 16.5% in adult keratoconus, failure rates in pediatric keratoconus have been reported to be up to 22% with conventional cross-linking and 17.7% with accelerated cross-linking. This might be attributed to different genetic patterns, higher biomechanical elasticity, and negative influence of other conditions such as VKC and atopy in pediatric keratoconus. So, to conclude, keratoconus in children has more severe presentation and faster progression as compared to adults. Cross-linking may be more effective in flattening of cornea in children due to more central or steeper cones. General anesthesia requirement may be reduced or curbed with high fluence or transepithelial cross-linking. Long-term follow-up data is still required to assess the efficacy and retreatment rate after cross-linking in children. And cross-linking done early on in childhood may offer significant cost saving in comparison to keratoplasty in the long term. Thank you very much for your attention.
Thank you, Dr. Vishal. Thank you for summarizing all the aspects of pediatric cross-linking. Pediatric cross-linking is always an area of, a gray area, whether we should go early, whether we should wait, and like that. Again, we'll discuss it and regarding the various aspects at the end of the meeting. Now let's move on to the next topic in this instruction course, that is customized cross-linking. We'll be having Dr. Shreyas Ramamurthy from the Eye Foundation Hospital speaking on the various aspects of customized cross-linking. Dr. Shreyas is a consultant cornea, cataract, and refractive services at Eye Foundation Hospitals. He did his fellowship in cornea and anterior segment from the prestigious L.V. Prasad Eye Institute, Hyderabad. His area of special interest include lamellar corneal surgeries, the ocular surface procedures including SLED, keratoprosthesis surgery, topo-guided treatments, intracorneal rinse segments, phakic IOLs, advanced refractive procedures like SMILE, and advanced cross-linking procedures like PIXL and customized cross-linking. Today, he will be talking on the customized cross-linking procedure.
At the outset, I would like to thank Dr. Sujith Nayanar and everyone at KSOS for this kind invitation and opportunity. Today, I'm going to be talking to you all about the outcomes of customized topography-guided cross-linking for patients with keratoconus. I have no financial interest in this presentation. So, brilliant microscopy studies have shown that while comparing keratoconic patients with normal corneas, the area of the cornea outside the cone seems to have a similar brilliant shift as that of a normal cornea. And essentially, it is only the central portion of the cone which is actually the weakest part of the cornea. So this kind of gave rise to the idea whether a localized treatment for normalizing the anterior surface or smoothening the anterior surface by selectively inducing stiffening in the weak zone, whether it will flatten the cone and improve visual function. So this was made possible by the advent of the KXL2 system from Avidro, or the PIXL system, which gives us a tailor-made cross-linking depending on the stage and location of the keratoconus. And what is really central to this customized cross-linking is the availability of specific patterns, customizing the amount of energy you can deliver across different zones, and the availability of an integrated eye tracking system, which basically enables us to center or rather decenter the treatment based on the location of the cone. We can have various patterns. We can either use sector patterns like this, or we can use concentric circles, and each of these zones we can distribute the amount of energy that we want to deliver. Generally, the highest amount of energy delivered is usually in the center and progressively decreasing as we go towards the periphery. Now, how do we center the treatment? So previously, studies showed centration based on the axial curvature or the sagittal curvature map, or you could do it based on the pachymetry. But both of these are highly influenced by the epithelium or the epithelial thickness, which we all know is highly variable in patients with keratoconus. So nowadays, we have now shifted towards using the maxima of the posterior float for centering the concentric circles or the sector maps that we use for normalizing these corneas. So what we used in our center, in our studies, is these concentric circles, where you have the central, which has the highest energy of 15 joules per centimeter squared, progressively going out to 10 and 5.4 in subsequent circles. So we wanted to compare this customized cross-linking with standard accelerated cross-linking for patients with keratoconus and see what amount of benefit we are getting from this customized cross-linking. So this was a prospective study done at the Cornea Services of the Eye Foundation. So what we did was a customized procedure where, by removing the epithelium in both customized as well as standard cross-linking, here the epithelium was debrided up to 7 millimeters, as we used 3 concentric zones of 3, 5, and 7. And we used the standardized size of 3, 5, and 7, irrespective of whether it was a very early keratoconus or a slightly moderate to advanced keratoconus. And all these were patients with progressive keratoconus. And the energy delivered was 30 milliwatt per centimeter square, pulse cross-linking, where as I alluded to earlier, 15, 10, and 5.4 in the 3, 5, and 7 millimeter zones. In the standard cross-linking, this was a accelerated 9 milliwatt per centimeter square for 10 minutes, for giving a total energy of 5.4 joules per centimeter square, which is our current standard of care as far as accelerated cross-linking for these patients with epithelium of cross-linking. So we did 30 eyes in each group and followed them for a period of 6 months. It has now been extended to 1.5 years, and the results have been stable, and I will go through each of these results. So the baseline data with regards to age, spherical equivalent, BCVA, Kmax, thinnest pachymetry was similar across both the groups. In the customized cross-linking group, we had a significant improvement in the IS asymmetry, thereby indicative of the amount of regularization we were able to achieve in the anterior cornea. There was a significant flattening of the K-mean and Kmax. The BCVA also was, there was an improvement, but however, it just fell short of statistical significance. All these parameters, however, in the regular cross-linking group, though there was a diopter of flattening which was observed, even in the regular cross-linking group, the difference was not statistically significant from preoperative measure. Just a few examples, as you can see from in the customized cross-linking group, from the pre-op to the post-op, the IS asymmetry has come down from 7 diopters to just 1.5 diopters. In this region, the cone is almost disappeared, and significant improvement in the anterior sagittal curvature. Again, another example where the central 3 to 5 millimeter of the cornea is much more regularized as compared to preoperative. We looked at the changes in the mean K in the standard and customized cross-linking group. And there was a consistent improvement in the customized cross-linking group. At around 1 month, it was the same, but at 3 and 6 months, there was a significant improvement in the customized cross-linking group, and the difference was statistically significant. The flattening of the Kmax also, the number of patients with 2 or 3 diopters of flattening of the Kmax was significantly higher in the customized cross-linking group. And in a direct head-to-head comparison between the two groups, the difference in the amount of IS asymmetry, the difference in Kmax, and difference in K-mean was all significantly better in the customized cross-linking group. We also saw that when we looked at the demarcation line, not only was it deeper in the customized cross-linking group, but we also saw demarcation line at different zones. The deepest being at the center, where we delivered the highest energy, and it became more superficial and more patchy in the outer zones as lesser amount of energy was delivered. Previously, studies have also looked into the recovery of corneal nerves and keratocytes in topographic guided and customized cross-linking groups using confocal microscopy. And they showed using confocal microscopy that the recovery of the corneal nerves, as well as the recovery of repopulation of keratocytes after the initial apoptosis caused by the cross-linking, was significantly better in the topographic guided cross-linking group than in the customized cross-linking. One concern is you're delivering higher amount of energy over the thinnest part of the cornea. So is there going to be any compromise to the endothelium? And in our study, as well as previous published studies, we have seen that there is no compromise to the corneal endothelium. The haze formation as well was comparable to that of standard cross-linking and was not higher in the customized cross-linking. Just summarizing the results of previously published literature as well as in our studies, where they have, this was a study, was the initial paper which compared conventional versus cross-linking. However, they used asymmetric arcuate shaped features based on the anterior curvature. Now, like I discussed, both the anterior curvature as well as the pachymetry can vary based on the epithelial thickness of the patient. And subsequent studies looked at concentric circles or varied patterns based on the posterior floor. Now, the thing with using a customized pattern is you could end up delivering energy to a very, very small area of the cornea of maybe just about 2 or 3 millimeters if the cone is not very well formed or if it's a very early keratoconus. And that is where we differed in our study, where we set out at least a minimum of 5.4 joules for 7 millimeters of the cornea. And then it was only the central 3 or 5 millimeters where a higher amount of energy was used. The reason for using standardized concentric circles was to see whether by using a standardized concentric customized data, we are able to achieve this kind of uniformity of results across varying degree of keratoconus. So we did see by using this standardized pattern, it gave us predictable results, definitely gave rise to better refractive and keratometric outcomes. And the future is, of course, combination therapy of using customized cross-linking with topographic guided treatment as well. And there is already an initial paper out from John Kanellopoulos, who has combined customized cross-linking with topographic guided treatment and has shown excellent results. So I do think that this is the future of cross-linking. And I once again thank you for your kind attention. Thank you so much.
Thank you, Dr. Shreyas, on your talk regarding the customized cross-linking. Many of us are not doing it. Thank you for sharing your experiences. And for the final talk in this instruction course, we'll move on to Dr. Sharon D'Souza, who will be telling us regarding the Pac Cxl, that is the cross-linking, the use of cross-linking in infectious keratitis, Department of Cornea and Refractive Surgery at Narayana Nethralaya. She also coordinates the Ocular Surface Clinic at Narayana Nethralaya. She did her fellowship in Cornea in Singapore National Eye Center as part of the Centered Educational Grant through the Asia Cornea Society. Her area of interest is ocular surface related conditions and surgeries, and also keratoconus and refractive surgery. I invite Dr. Sharon D'Souza to give her talk on Pac Cxl, that is cross-linking in infectious keratitis.
Hello, everyone, and thank you for giving me this opportunity to speak in the prestigious KSOS conference. Today, my topic for discussion is on the use of collagen cross-linking for treatment of infectious keratitis. So as we know, corneal collagen cross-linking is used for the treatment of corneal ectasias, mainly keratoconus. And in this procedure, we use riboflavin or vitamin B2 and a UVA light of a particular wavelength, which helps us by allowing the collagen fibers to get more stiffened by increasing the bonds between them. The use of cross-linking for treatment of keratitis has been termed Pac Cxl, which is an acronym for photoactivated chromophore for keratitis. And the basic idea is in patients who are not responding to our conventional management, this treatment may help them or at least stay the progression of disease. So how does Pac Cxl work? So there are three main proposed mechanisms of action. The first being that the planar ring of the chromophore, which in this case is riboflavin, intercalates between the DNA-RNA bases of the microbe. By intercalating, it causes lesions in the chromosomal strands of the microbe and thus limits the microbial replication. So that in a way would reduce the worsening of the condition. The next proposed mechanism is that during the process of cross-linking, there is a release of reactive oxygen species, and these would directly damage the cell walls of the various pathogens. And the third mechanism is when the chromophores actually cross-link the corneal stroma via covalent bonds. That we know is how corneal collagen cross-linking works. But in doing so, it changes the tertiary structure of the fibers, the collagen fibers, and the sites of collagenases. So the corneal melting, which occurs in many of these keratitis, would reduce and also makes these corneas more resistant to enzymatic degradation. So the indications of trying collagen cross-linking for an infective keratitis, mainly, of course, we do know that there has to be a keratitis there. It's usually a larger diameter, not at the first presentation. If the patient also has a corneal melt or some amount of collagenolysis, they are supposed to respond better. And of course, it should usually, at least till now, we have relegated it to patients who have been refractory to conventional antibiotic or antifungal therapy. So the contraindications, of course, they have said that herpes simplex or any herpetic lesion is a contraindication for trying this because it can get worse. Perforated corneas make sense. If the eye is already perforated, we don't want the riboflavin entering, or the UV effect, we don't know what it will have on the rest of the structures of the eye. Of course, you're not going to try it as a first resort. So coming to the surgical technique of this procedure, most of the studies, and including ourselves from our experience, which I'll be speaking about, have followed the Dresden Protocol, which involves use of 0.1% riboflavin drops, a soakage for about 30 minutes, followed by a UV light at 3 milliwatts per centimeter squared for another 30 minutes. The modifications of the standard protocol have also been tried. And of course, there you would either change the UV treatment time to make it an accelerated protocol of cross-linking, or there are studies which have tried a transepithelial approach. The logic being that, of course, in ulcers, there's already an epithelial defect in the ulcerated regions, and you don't need to scrape off normal epithelium or surrounding epithelium for the penetration of riboflavin, as it may already penetrate in the area where there is an epidefect. So this is our experience. We published this article in the British Journal of Ophthalmology on the use of collagen cross-linking in the management of advanced non-resolving microbial keratitis. This was quite early when Pac Cxl was described, so we were quite conservative in the patients whom we had chosen, and relegated this treatment to patients who we were planning, who would otherwise require a therapeutic keratoplasty. The indications would be a patient of microbial keratitis, preferably not a very deep one. So you don't want something which is already involving the descemates or endothelium, nor a perforation. And they should have, our criteria for including them was a non-response for at least 2 weeks post it. So these are some images of our patients. On the left side, you can see that this was one of the patients. There were 15 patients whom we enrolled in this study. The preoperative bacterial keratitis proven on corneal smear with an anterior stromal infiltrate and a hypopion. Now, post cross-linking at 8 weeks, the infiltrate did reduce, but the hypopion did show a persistence. Okay, and I'll be coming to a little more discussion on that. This is another patient whom we had included in our procedure where this was a fungal keratitis. And post this again, there was a resolution of infiltrate, but surprisingly, the patient developed a hypopion, which again took a while to resolve with medications. All these patients were continued on their routine medications based on their microbiological tests. So this is the table which shows the various patients and their responses over time. But just to try and make it a little more succinct, one important point is that they did have symptomatic relief. So very early on, much before the clinical changes, some did have clinical relief. And the point which I was mentioning earlier is that there was an increase in hypopion, or a new hypopion formed by the third postoperative day. And that was a learning experience for us. And even now in literature from other groups, we've seen that people who have a hypopure corneal ulcer, those patients have not done too well with this procedure. It still took quite a long time for the epithelial healing and the infiltrate to heal. So it's not that it's a magic bullet. It still takes a few weeks to gradually reduce, but there were some promising results. Of course, in spite of all this, 4 of these patients just went on and they required a therapeutic keratoplasty. So other groups have also published quite interesting work on this, including Dr. Venkatesh Pratnaya et al. But they found that there was no benefit to adding on in a filamentous fungal keratitis. So they seem to have similar outcomes, especially if it was a mild to a moderate filamentous fungal infections. They appeared to have similar outcomes when they were treated with our medications like amphotericin or natamycin. Another very interesting study, and there have been many studies, and including some meta-analysis which have been done on this subject, but they have found that it is beneficial for treating, and especially in patients who have some amount of keratolysis, as I was mentioning earlier. But it is more effective in bacterial infections than when it comes to fungal, and acanthamoeba infections have been found to not do too well with the collagen cross-linking. So there have been multiple publications, as I said. So it's always an alternate adjunctive treatment that has been described. Better to have a more superficial infiltrate, and that makes sense because we know that the cross-linking effect is usually till about half or 2/3 of the cornea maximum, so around 200-250 microns in a normal thickness cornea. So anything which is very deep may not have that much of effect. And repeatedly in all studies, one clear point that runs through is that we need better characterized protocols. We need a little more structure when devising these studies to actually assess how well these patients can do. So the investigations or the research which has been done have a lot of varying results in them. And this can be attributed to certain points. One is that some have different study designs across different literature. There's no well-defined dependent variables like the infiltrate depth, the ulcer area, size. There are a lot of demographic differences between groups, and no standard operative or post-operative regimen. So most of them have followed the Dresden Protocol, but some have tried accelerated regimens as well. And the inclusion-exclusion criteria also vary. So it's very difficult to compare results across different studies. This procedure is not without its own list of complications. So as I was saying, even in our study, we found that the hypopure increased in certain patients, even though the infiltrate seems to reduce. And of course, it can progress to corneal perforation. That's probably a worsening of the clinical condition which is existing there. Studies have shown an exacerbation of herpes simplex keratitis, and it therefore becomes a contraindication for trying this procedure. And of course, as we know, UV light itself can damage the endothelium and cause loss, and that itself induce corneal edema. So these complications have already been reported. So definitely we need to be quite careful when using the procedure. From all the literature and our own experience, I think the take-home points to this would be that a smaller ulcer would show a higher success rate, but very rarely do we use it in a smaller ulcer. We're more dependent on our conservative management, including medications. Success, as we define it, or we look on the patient, is by resolution of the epithelial defect and reduction of the infiltrate. Eyes with hypopure had a worse prognosis, and this was shown in our study as well. And of course, a deep stromal involvement has less successful treatment. So a larger ulcer, but a more superficial ulcer would probably do better. So when it's nearing the limbus, that you want to avoid that, maybe that's a good indication. And definitely contraindicated in eyes with herpes simplex keratitis. So I hope that was useful, and thank you very much again.
Thank you, Dr. Sharon. Thank you for sharing your experiences. Now we have completed all the talks. Now we can spare some time to take the audience question and also to discuss viewpoints that we have been talking for the last 1 hour.